for joining us just before 1:30.
That's great.
The second action was to provide an update on the estate risk that had previously been presented to the public board. That risk will be encompassed in the refresh of the board assurance framework and will be brought back to the board in due course.
Thank you. And then the other two are?
The other two have been scheduled for future meeting.
Thank you. That's really helpful. Any comments on that? So we're going to start off with our patient engagement story, and I'm delighted that Professor Parker Baludi is here. I'll hand over to you, Parker.
Thank you, Chair. Thank you all. Sorry. Okay, for me to be here?
Yes.
Well, a few weeks ago when Teresa said, do you want to come and talk about your service? There'd been some positive comments from patients, a particular patient who's done a video. I thought, okay, we'll present something to the board. And I know you've spent most of the morning with numbers. So I thought maybe you don't want to hear numbers. And you don't want to hear the technical details, but you really want to hear the essence of what drives us. And why are we considered successful as a service on island, which is a unique concept, not being successful, but being on island and delivering this kind of service. So the story starts in 2018. This is when the service was fairly rudimentary. We had 3 dermatologists, 2 part-time, 1 visiting, a small band of nurses, myself visiting a day, a month. That's all that the island got from skin service. And we started off. And we started looking at what do patients want and what do patients need. And they don't always mean the same thing. We knew that patients or the public quantify quality with time, waiting times. How long will I wait is an important quantifiable measure. But patients didn't understand what quality meant. What was safety netting? What was governance? What was integration? They liked the idea of having one individual or one person take them through their journey from beginning to end. They liked that, but there wasn't that in place. So it gave us some things to work on. We had drivers, and we actually got those from the community, from the patients. We'll go to the next slide, please. For us, the journey has been about collaboration and community. And collaboration sounds like a word that's used, thrown around loosely, but there are many layers of collaboration here. So we started within the team. How do we work within ourselves? Our nurses, our dermatologists, the surgeons. We compared what we were doing to waiting times, to what our objective measures were. We changed the way we were working. We gave more focus to new patients. We moved certain follow-ups aside. We changed the way we were seeing our dermatology patients with teledermatology, and that's when innovation started building in. But that felt isolated. It's not just us. And this is one of the biggest problems we found to be not just on the island many miles away from mainland, but actually the the island in some ways geographically didn't help patients get to the north of the island. It seems like such an effort to get to the north. What okay, but that aside, being a clinician on the island, being an enthusiastic clinician on the island, meant that I needed to flourish and grow my discipline. And for that, I needed to reach out and collaborate with colleagues in the UK and on Ireland. So we started very quickly collaborating with GPs and set up GPs with extended role training with the dermatologists. We set up links with Clatterbridge so that our patients got their treatment on island and they didn't have to travel anymore. Their telephone consultations with our patients, gave guidance to our oncology nurses, which I think Manx Care was the first to set up that service. Our MDT coordinators were our partners. And again, we built that team so that we looked after timelines and reduced the risk of patient falling through gaps. But most importantly, patients now started seeing through that collaboration an end-to-end pathway where the GP or the community spoke with secondary care spoke with tertiary care, we spoke with a hospice, sometimes end of life, but usually end of treatment. It became more and more integrated, and that was critical. And then we moved on to the community. That's been really the soul of what we've done. Because the community has sensed our passion, our motives have been the right ones in the right way. We've had some incredible support, not just from Ramsey, who are very proud to have us there, but from the rest of the island who feel proud to travel up and actually stay the night over because it's been such a long journey. But in all honesty, we have built a community around our service. So much so that the patients wanted to support each other and they formed a network. We facilitated that network. And that network is growing. And one of the videos that's come through is from someone who is an active member of that network of patients who support each other, involve us for education events, but really grow awareness and give us impetus to progress. Innovations have been strong. And thanks to Manx Care for actually supporting us with that. So COVID was difficult, but we set up teledermatology and that helped oncology. And now we actually don't have an on-island dermatologist. We've struggled to find an on-island dermatologist. So we have a virtual dermatologist most of the month. And for 3 days of the month, we have a face-to-face dermatologist who visits us and she looks after our patients. But otherwise, she's in London with her team, giving us guidance with the photographs we send. And we now have a 24-hour dermatology on call through that service, which we never had. So our service has actually gotten better with innovation. We've worked with transformation. We're looking at getting AI for dermoscopic, which is a microscopic image of the skin to look at certain lesions. So we're using technology to help our clinicians who we don't have that many clinicians around us to help work with that, but to actually give us better quality and move through quantity. So bottom line is, the next slide. We've used innovation, technology to actually bring our service to a place where we're proud of. I know I'm running out of time, so stop me when you're ready. I'm really proud. I think I can, from in the 5 years we've been operational, we've maybe had 4 complaints that we've had to, and most of them have been very genuine reasons why people make complaints. And we've worked towards them. Waiting lists is one of the main issue. Why do we have to wait so long for a certain treatment? And we've worked towards it. Um, I won't quote compliments. There are many, but they are very team focused. So the team is what the patients keep talking about. That sense of being looked after cannot be quantified. So when we look back at what we've achieved beyond the certificates and the innovations and the numbers and the finances, that sense, that emotion that patients put in their messages, that which cannot be quantified is what we deliver. And I think that's what makes us successful.
Yeah, so the reason why I chose this service to particularly present today is we're on the precipice of a very different approach to delivery of health and care for the island. You know, the operating plan gives us a huge number of challenges, but it also presents great opportunity to do things different, to embrace different ways of delivering care, to look at digital, to look at using our workforce differently. Dermatology is probably one of the most hardest to recruit to specialties. We've had great success elsewhere, but this team was recognised in the CQC report as being quite outstanding. And it is outstanding because the way the whole team works. So it just felt quite symbolic that this is the team that's had no less challenges to deal with, but has approached all of those challenges with solutions around workforce, around innovation. And so, you know, and the patient feedback is outstanding. The patients love the service. And the videos are too long to show, but the links have been circulated, so you will hear firsthand what the patients think about the service, but also the support they're offering to each other and that connectivity to the community, which is so important and what really epitomises great integrated care and great island life. So it just felt like this service absolutely symbolises where we want to be as an organisation and trailblazing how Manx Care will always want to do things differently, but with that real connectivity to community and to the population we serve. So thank you, Arthur.
Thank you.
Yes, please. Yes. Arthur, thank you very much indeed. We know each other, of course, and I have to declare an interest. I was born and bred in Ramsey. So this is very important. But seriously, a long way north. Take a packed lunch and a space blanket. Yeah, but seriously, you talked about collaboration, alliances, team building. You talked about being community driven. We spend a lot of time talking about numbers. So it is very refreshing to hear you talk about those drivers to change that you used and encouraged in your team, which is, I suspect, clinically driven as well, because you're getting better results from that. And I think we are in a period of change. We do need to change. There is pressure on numbers. That's no secret. But in order to change the numbers, we have to change the way in which we do things, because one follows the other. The numbers simply tell a story. It's what we do and how we do it that will change the numbers. So I'm really interested in understanding if colleagues in the service are observing what you are doing, and are they treating you as a beacon for change, or are they treating you as a threat?
Uh, One of the advantages of being in the north, if there is threat, it's still far from us. Okay, I used to be wearing a different hat. A few months ago, I was CD for cancer services. And one of the things that I took from my service to the cancer world, for example, was the collaboration with different sets. So quality control, when you work in an isolated environment, you only see what's around you, and there isn't enough integration with the UK. So what we did very quickly, actually it's only in the last 3 years that it's happened during Manx care, that we've integrated with the Cancer Alliance, and every cancer tumor site has integrated heavily with their CQGs, their care quality groups in the UK, particularly the Northwest. So we've ramped up quality by actually looking at what is the standard expected in the Northwest of England. Are we seen as a beacon? Well, we are an oddity because we are a one consultant band of nurses primarily. I have a CNS, um, a senior nurse who does surgery, who I've taught to do surgery. She's a very skilled surgeon. We have healthcare assistants who run their clinics, but they are taking data for a dermatologist. We have nurses who do phototherapy, who do dressings for burns. We have a unique setting and a unique team. What can be drawn from this for other teams? Well, I think this use of skill mix, how to push yourself to the maximum at what your license allows, how to actually be open to new challenges, and that idea of, no, I'm trained to do this and I will only do this, we've had to shed very quickly. And we've had to move to, you're doing this today, tomorrow you're going to be doing something very different, and the third day you're going to be doing something very different, and you're going to have to learn a few more things. That open-minded, healthy approach within a team, I think that sort of general message is what I'd like to put out there. And that's what I think we've excelled at. But every specialty is doing really well in their own way. Ours is rather unique in the sort of messages it gets sent out. I think the messages are healthy team working, but also not working in isolation, reaching out to partners, seeing, constantly sense checking, you're doing the right things for the patient.
Thank you.
So I visited Ramsey and got mugged by two of your nurses and taken in to see work. And it was extraordinary because, first of all, the flat hierarchy you've created really encourages professional teamwork. It was really impressive. Their ambition for the service was huge, and their expectation that they would be driving that ambition forward and looking for the resources. They weren't looking for can we please have? It was a very positive experience. And I met some of the patients, I think it was phototherapy day, all of whom spoke really highly of the level of personal contact they felt with their clinical team. At no point did someone say, I haven't seen a doctor. It was their clinician, and that message really shone through. I'm really interested in the application of technology, so I'm delighted that you're exploring the AI space.
Yeah.
And I think your representation of how you link with colleagues in the UK, that is the modern tertiary service. Tertiary service can't just be putting someone on an aeroplane somewhere. It's got to be about the learning that that brings back into the team and that free flow. So I commend you, because I think much of what you said encapsulates the message you're trying to get through in the operating plan far better than we can write it, because it's the reality of what you're living. I guess it's a question around how we use you as an exemplar to perhaps show clinical leaders that change isn't always something that you have to do because it's imposed by financial constraints, because actually it's the most exciting way to have your professional career. I think that will be a really important message for us to get through to people, so thank you.
Yeah.
Tim, then Sheila.
Thank you. Thank you. I just wanted to say that I did look at the patient story, the videos. I'm sure many board members did themselves, and I was just really impressed by the narrative which was given, particularly around self-support and being supported by groups of patients and being enabled to take control. And I think that's something which is really important. We all know that health outcomes are better for people who feel that they're in control of their treatment and what's going on for them. So I think not only have you had innovation in a range of areas, you've also done the other thing, which is to empower your patients. And I think that's to be hugely commended. Thank you. Thank you.
Sheila.
Thank you. And thank you for telling that really impactful, real story of what's going on for the communities that we serve. And you really do have a clear view of the patient must come first, and the voice of the patient and the involvement of the patient and the engagement of the patient. But I'd like to allude to what Wendy was saying. You're a leader of a really strong team, and we haven't necessarily got a lot of people like you. What three things would you say to other leaders of services such as any service? What's the three things as a very strong leader would you say to other leaders?
She got me on the spot. But no, okay. It's very much around the message is there. Don't work in isolation. Reach out at every level. Community, GPs, tertiary care, and palliative care. You've got so much to learn from everybody, and actually the patient gains from that collaboration. That's one. The second, as an island, I haven't been here that long, and I think I'm still what's the term?
Come over.
Come over. And will I become a stopover?
10 years.
Okay. The island is unique in the way it will think, and every island is going to be similar. I think the island wants to see people come and flourish and do well for the island, but with the right motivation. I think if people see the right motivation and the right action that follows, they will support you. So, involve the public and involve your patients and involve these. I believe these are the decision makers on the island. So you take everyone with you, and that makes a bigger difference on the island than I see in the UK. That's my second message. And the third, one of the biggest problems I see here is getting the manpower. So using innovation, technology, whatever, to build resilience is the key. My team is resilient. if I come under a bus tomorrow, my team know what to do. Whether they find another plastic surgeon or not, they know which patients to direct to specialist GPs who we've trained, which patients to direct to the dermatologist. Susie, my specialist nurse, can do certain procedures. The system will carry on with or without me. That level of independence within a team and future proofing is required. The island is too reliant on single points of failure.
Oliver, then Tim.
Sorry for the long answer.
I think, congratulations on such, developing such a, an effective service. One of the things you touched on there is GPs with extended roles. And one of the things that Manx Care is looking to do is bring care closer to people's homes, nearer to where they live, in hubs. What lessons do you think there are for other areas in the health service in Manx Care for putting services closer to where people live? Because it seems like it's a great success in dermatology. What can we learn from this experience?
Thanks, Oliver. It's not been an easy road. GPs with extended role in dermatology, we've trained them. It's been really good. It's taken time, it's taken efforts, and the GPs who've been through that journey have worked so hard to get there. So it's going to take a lot of effort for people who are comfortable in their jobs to take that extra step and learn a new process. And your colleagues have done that amazing step. And that has really enriched the way we can now deliver dermatology. And you meant spoke. I know the hub spoke.
Yes.
We are the hub. The GPs are the spoke. And there are multiple spokes. And that's how we deliver at different sites on the island. I think there's a lot of specialties that could do that. In the UK, we have hubs that take the activity away from acute centers to hubs where photography, imaging, blood tests, and certain clinics are run. The island is too small for that. I think those hubs should, and what we call spokes on the island, should take place in certain select practices that can actually take this up. I would have thought chronic conditions, elements, for example, I'm guessing here. So the relevant specialists shouldn't shoot me down, but rheumatology, for example, diabetes, geriatrics. I can see these specialties being looked after much better in their local environments. At least the follow-ups, the aftercare. And yeah, I think that should be something to look at.
Ask some questions, Tim, then Simon.
Thank you, Bob, for a brilliant presentation. I'll be really brief. So, building on Ollie's point, actually, you've just described really neatly and much better than any of us can do what we might be aiming for in terms of integrated working in localities, building on your point. So, just to say, I'll be checking my passport and I'll be coming to see you in Ramsey if I'm allowed, just to talk through that in a lot more detail, because the how of how you've achieved that is attracted everybody's attention in this room, as you can see. And the final point is, you haven't mentioned it, but it's absolutely, you're creating a culture of continuous improvement, of doing the best you can for your community and sharing the load from a team point of view, and that's to be absolutely applauded. Well done.
Thank you.
Everything you've just said, but also thank you for the summary. I thought it was excellent. But I really love the piece on how you've developed your team to get to the top of their professional licensing,
Yeah.
for example. And I think that's something that we need to get across the organisation, because first of all of those staff, they will be great ambassadors for Manx Care and for what you guys are doing out there. And they'll be sharing that with the patients because they're close to the patients, and they'll be talking to the patients, and the patients will see how happy they are in the job. And I think that means that they're great ambassadors for Manx care. So I think that's a really big win, and if we can get that across all the other specialties, it would be fantastic.
So Arthur, thank you. That's been really helpful, and I think to re-energise us after a morning of talking numbers, as you say. You get the prize for today because you're the person that's come to the board not asked for anything. So, but no, it's a really impressive service, and I'm sure you'll get lots of requests and visits. But please say thank you to yourself and your team. Convey our thanks to them for the work that they do. Very much.
Thank you.
Yes. Elaine, is there anything? Yes. Oh, brilliant, perfect. Okay,
What is
Single organ.
Neil, to introduce you. You're very welcome. Thank you for sparing the time to come to us in person. We've got the board and then members of the public in the room as well. So I'll hand over to Tim to say hello.
Thank you, colleagues. So it's a really warm welcome to Leslie Walker, who's our independent chair on our safeguarding board here on the island. Spent a lot of time together, so it's great to see you here again today. And I think the first time the board has heard from the independent chair, which is fantastic. Really keen to do that. Leslie's role is broadly around assurance and both holding a mirror up, but also helping us to drive some of the change and improvement work we need to do across the island. And without kind of repeating some of the things you're going to say, one of the things that I think you've already brought to the table is consistency and the right level of challenge for us to make those improvements. Yeah, we've got a few minutes today to hear from you, and also hopefully ask some questions of you in terms of how our progress is going and what we need to do next. So thank you, Leslie.
Okay, thank you for the opportunity. So it's great to be able to come to speak today to the Manx Care Board, because obviously Manx Care are a key partner in safeguarding and providing so many of the services around safeguarding and protection of vulnerable adults and children around the island. And obviously also just to say thanks because the range of work that staff are really, just to give the flavour maybe to the board of the range of work that staff in Manx Care are involved in, not only in terms of the recognition, the assessment, the prevention work, but also just that contribution, the multi-agency audits that we undertake, how staff have really facilitated and helped support the board in hearing directly from the voice of service users has been such a strong piece, and I'll just mention that later. Practitioners who have been really open and honest about some of the challenges and really keen to be reflective around that and help think about what we need to do to change and improve not only safeguarding within their own service, but on a much wider basis. So that's been really encouraging. So just to be clear, the Safeguarding Board is a partnership of its agencies. So it's the agencies that sit around the table, of whom Manx Care Chief Exec and Tim as the Executive Director are absolutely key in terms of the role they play, along with our independent members and all of our subgroups that go together in terms of that partnership to bring assurance both about single agency practice and multi-agency practice. But the role is also to drive forward those multi-agency pieces of work. So it's not just about assurance and looking at effectiveness, which is a big part of the role, but it's also that part about driving forward, as Tim has said, some of that improvement work. So you'll see within the annual report, and obviously you know, it feels behind in a sense that we're just at the stage now of developing the 24-25 report. So I'll just touch on a couple of highlights that I think might be useful for this board to hear. But we've kept, you'll see the priorities for the 23-24 in the report on page 9. But we particularly have kept some of those key priorities. So both ensuring effective multi-agency practice for vulnerable adolescents is a big piece of work that we're doing in conjunction with Manx care staff in particular, and children's services, children families, and then the work around adult safeguarding and vulnerable adults and children is absolutely key. And then our other priorities we have also got in response to the reviews that are mentioned in that report is around childhood neglect. So that is a new priority for it's a 3-year plan we have developed. I got so many questions about that, and also embedding learning to improve practice. So what have we learned as a system, and how do we bring that forward? But most of last year, the last year has been focused on that assurance and evaluation of effectiveness. So a lot of the early stages of the board were about just making sure the bedrock was there on which to build practice and improvements, training, policies and procedures, all the things you'd expect to be in place. So we've undertaken several pieces of scrutiny, but 2 of the biggest pieces were around that significant work to improve the response to young people who are at risk of harm outside the home. So what sort of things I'm talking about there are things like criminal and sexual exploitation of young people, which is a very live issue and a real risk to children and young people on the island. And then the other piece that many of you will be aware of, we had a very sad serious case management review a couple of years ago that looked at the learning relating to the deaths of 7 vulnerable adults due to self-neglect. And picked up on big issues of improvement that was required across all agencies. And it's great to say that there's been a real sort of push and engagement from staff around that particular piece of work. It's mentioned in the report that we were going to do a piece of scrutiny. I've just completed that, and the report has been signed off by the board, so I'm happy to reflect. You'll see it in next year's annual report. But it really, for me, evidenced the strength of collaborative work and work with partners, because we saw huge improvements. And the service users that I spoke to, all who'd had some involvement from Manx Care Services and particularly adult safeguarding, the journeys that those people had been on in terms of, and the improvement that could be seen in their lives. There were quotes like, "I wouldn't be here if it wasn't for the staff that made a difference in my life. You know, I just wouldn't have survived some of the circumstances." And sadly, we saw the very sad outcomes for some individuals who didn't get that level of support, wraparound and improvement. So it was a great piece of work to hear about in our board, and I think for you to reflect on at this board about the impact that had on service users. So still some areas that we picked up that we still want to work on, but a great story about the effective collaborative work and working really closely with staff from Manx Care. So I mean, that's a whistle-stop tour. I mean, the only other thing I would add is that Manx Care, one of, I said, our big issues is around really ensuring that quality and assurance and improvement around key bits of work. And I've said in some of my recent reports that really needs to be strengthened. So where you can support our work is around that strength of your assurance on internal pieces, because we need to see really strong evidence-based assurance. We can't just as a board say, yes, you've told us it's improving. We need detailed evidence of that. So quite keen on that. And we're really keen to support any conversations about the shift, and very live issue now, and the shift in terms of both resources and focus, but mainly focus on that early intervention prevention piece is absolutely key to improvements in terms of safeguarding, because if we don't, and the parents that I spoke to as part of our exploitation scrutiny were very clear in saying we can see the trajectory in terms of our children, we can see many of the issues that they were experiencing, many of them issues with neurodiversity, and other conditions that made them particularly vulnerable and susceptible to those sorts of abuse. And then speaking personally to myself, many of the adults who had suffered or who had experienced maybe abuse and trauma in their own background, and how that led them then to issues potentially around self-neglect, around hoarding, around poor mental health. So we can really see the need for that early intervention, prevention, and also adequate step down arrangements, I would call them. So the support, once people have had a high level of engagement, what support do we have in place to make sure that things don't deteriorate again for those individuals? And you'll see when you see the next annual report just how much we're emphasising that staff, particularly in Manx Care, are really going above and beyond in trying to support people even after their involvement has ended, to maintain that level of improvement sometimes it's been made in their lives. So it's a tricky area, and something that we need to have many more discussions about at our board, and for myself with politicians, etc. as well. So that's a real whistle-stop tour. Hope that's helpful, giving you a little bit of a flavour, and happy to answer any questions.
Leslie, thank you. That was really impressive. It's a really helpful report as well. And I'm delighted you've highlighted the areas where Manx Care has got both a role now, but an expanding role as we get into more of the prevention and early intervention. It's a passion of ours, and it is what an integrated Manx Care should be doing. So thank you. I'll open the questions. First of all, I come to Chris, and then to Tim.
Thank you, Leslie. I have to say, I think it's phenomenal, the work that's been done. And I think folk that have been involved in this journey should be really proud of the journey. In part of my prep for coming over to the island, I made a point of looking at safeguarding processes here, and I've got a good understanding of the journey. In just a few years, you referred to the bedrock, and then work now on assurance, and have got to a position where there are many areas of the UK that will be looking in awe really at the consistency and the approach, the methodology, the focus on assurance that you've managed to get to here. I mean, I really do think it's an amazing journey. I'm also really glad of how much distinction you're putting between children's safeguarding and adults. I think many people think of safeguarding, or historically many people have thought of safeguarding as being about children. In fact, safeguarding in adults can sometimes be much more complicated and requires much more collaborative working. So that focus, I think, is great, just to remind us all that it isn't just about children.
Thanks, Leslie. And just to repeat what I said before, I think having you on board as the consistent independent chair is really helping us to kind of put the mirror up to what we're doing. But also working along in partnership in some of these really tricky issues that we're dealing with. Just a couple of quick points. The evidencing point, we're working in some service areas at the moment together, aren't we, where we're struggling to get the message across about what constitutes first-class evidencing of improvement. But I think what's great about our approach to the partnership is we're not resting on that. We're having the hard conversation, and I'm very happy to work alongside you to have that, because we are starting at quite a low base in some parts of the partnership. I think it's fair to say I'm still quite close now. And then
I'm happy to support in whatever way we can in helping with that.
You absolutely are. Yeah, you absolutely are.
What knowledge or experience we might have in that area.
And that's incredibly helpful from my point of view. The other one is the thing we're going to watch for, of course, is what we're uncovering is more need we didn't know about. So self-neglect being a great example. Of course, we're dealing with that, but if my idea was in the room, we'd be saying this is now getting quite tricky. So the early intervention part of your story and our story is also really vital. And I know you and I align on this in terms of pushing that wider partnership to think about investing more in early intervention or changing the way the service is delivered. to do more early intervention, and I think we form a strong alliance there. We're not yet winning that battle, but I think we've won a few minor skirmishes and keen to do more in that space, because I think if there's one thing that I could predict we both say is that that's still a big frustration for us on the island. We have, as Chris said, made good progress in a relatively short space of time. Until we fix that issue around early intervention, we're going to still be struggling, I think, with increasing need.
No, I would agree, and just to remind members of the board may not be aware, just it was the time that I started was the Child J review, which was a child with a young person with very, very complex needs in the hospital setting, who almost died because of the particular circumstances, and the issues were around that exploitation, that risks, drugs, criminal exploitation, very complex. It made a recommendation for the island around that early intervention prevention piece. It was, after much lobbying, put in the island plan, but there is definitely in terms of, I don't think the delivery of that has really been pinned down, and I know we are continuing to the sort of challenge, and I certainly will, around that, because it is the biggest barrier, as I see, to effective safeguarding, unless we're getting that early identification and early input into those situations improved in the way it needs to be, Tim. So thank you.
Last question to Tim, and then we'll finish with you.
Hello. Thank you very much for the report, and something which isn't connected to safeguarding, but it was really great to see a report which set out some demographic information right at the front, because I think we for those of us who don't live here, I think that we make assumptions about the demographic makeup of the island and the people who live here, young people and older people, and to see that right up front, I think is something that we could learn from as well. Really good to hear about. I was going to ask about the work on self-neglect, and really good to hear that after the review, progress is being made, and that's continuing. I mean, also just to reflect that, I guess there are significant issues working around neglect in particular, and with adults when there is no capacity framework on the island, and that's something we've already mentioned elsewhere today. And I think that anything that unitedly we can do in terms of making sure that we get the right capacity framework. Obviously, there's lots of learning from the UK, and they've been reviewing theirs again, but to try and get that a capacity framework in place, and also just to recognise, I'm going to get the acronym wrong probably, because I always get confused between IDVAs and the other acronym, but just so that recognising that I think we've got our first domestic abuse coordinator connected into Manx Care, and that's a real step forward as well, and that's something which I think we really value and will be very helpful for us and the people who we work with. Just also wanted to connect with on the younger people's side, really important enabling the voices of young people, whether they are young people who are looked after or are part of systems, making sure that those voices are heard. And that goes to part in terms of the grooming and exploitation, and hearing that, and there being a place for that to be heard and amplified, so people are taking note of what young people are saying is really important. And then for me, there's that connection with schools and education. And I was just going to, that's my only question in all this ramble was really what's your take on the level of cooperation and co-work between Manx Care, health, and the education system in particular, thinking about schools and how that interfaces.
Yeah, no, I'd say that's working, very positively. We're having those often complex discussions around the board, and we're going to do some development with board members, because we recognise that increasingly we're having to, some of the things that were coming out, for example, that exploitation scrutiny, in terms of, we know that children who are out of school or missing education, are more at risk of those type of harms. So how can we work in that? There's already identified issues, certainly coming from the UK context in terms of the, in England, the National Panel report in terms of children who are electively home educated as well as you know, having a very high prevalence in some harms, and how can we work together? So we're, you know, we've been talking about what changes to legislation even that you know, that we need around that. So those collective, you know, just discussions are happening, and it's really important that through whether there's, I guess for me, where there's challenges in terms of island finances, and that we don't go into siloed working around those particular areas, because we can add so much more value, you know, by working together. And maybe, Tim, just to reflect that certainly I think there's certainly work for the partnership as a whole to be done around that voice of service user. Although we've got some good recent sort of evidence of that, and particularly in terms of self-neglect. It was wonderful to get to speak to a number of adults that have been self-neglecting, which is very hard often, but that was facilitated by staff. But it is something that we need to be really strength. It's a key triangulation point on what are our service users, or those who are providing services to, telling us about the quality. And I've actually just done a piece of work, again facilitated by staff and children families, with some parents to hear their voices about experience of service. But it is something I think that we need to develop, certainly more so. So I hope that gives some assurance around those couple of areas.
Final comment, very quick, Chair. Hi, Leslie, I'm Sheila. I'm the exec nurse, and I'm used to managing safeguarding when I've been an exec in other organisations. I really like your annual report. As you said, it's late. It doesn't matter, it's here. And it's really, really good. I just wanted to ask you in terms of, I'm used to those terms, think family.
Yes.
And I think that's where Chris is alluding to. We automatically think it's children and maybe paedophilia or something like that. It's usually neglect, actually, and that is the biggest issue. In terms of your report going forward, your annual report, will you be looking at not only looking back but also looking forward for the next year as to some pointers that you might be thinking about for the following year?
Yes.
That we could certainly make sure that we were part of that and part of your looking forward plan.
Really helpful, and that was part of the reason for us having a 3-year business plan now, so that we're trying to map more clearly what's planned, not you know, not just over a year or 2 years, or you know, that we need to have that forward plan to be very clear about what we're working on. And some of the issues around the Think Family agenda are going to come out very much out of a review that's currently ongoing, and how we need to you know, to really improve that in terms of when we either out with adults, making sure that we have got eyes on the children. Likewise, when we're out with a concern about a child, what is that telling us about that vulnerable adult, the mental health potentially, you know, and what input that we need to do. But yes, what we want the annual report to be. So this year, the one in front of you is a step forward from previous ones, but we're not all the way there. We're trying to be very impact focused and on further work, but it's not quite where I would want it as yet in terms of, and you see very variable reports from safeguarding partnerships and safeguarding adult boards around the country. So we just want to try and pull the best of those and think maybe creatively how we can use better means to get the messages out there. For example, you know, Manx Care staff have been great in terms of the safeguarding week. You know, and that we've never had safeguarding week, so we've had 2 now, and we're planning already for this year's. So things like that. How do we get messages out there about what we need to be thinking about and what we need to be focused on? So I think the challenge, that's really helpful.
Leslie, thank you. That's been really comprehensive, and I hope you've got the message that we're massively supportive. We want to be engaged at every step of the way. And I think it'd be really great if we could agree that you fund after your annual report each year, because I think that it's a touch point for the board to just check that we are doing what we said we'd do.
Yeah.
So thank you very much indeed.
Okay, thank you so much for the time.
Pleasure.
Thank you.
Travel safely.
Going on holidays. Thank you very much.
Thank you.
Thank you.
Bye.
Right, thank you. So moving on to the next item, the board assurance framework. This is, as we said before, a work in progress. Be improving the presentation of this, but it's really important that we have this available to the public as a record. So Elaine, over to you.
Thank you, Chair. Yes, so as you just alluded to, the work to refresh the BAF is ongoing. We have started it, and we've got a session with our non-execs tomorrow to go through a workshop on the board assurance framework. During the reporting period, there have been no changes to the key risks or mitigations. There has been one risk that has been reviewed, which is risk 1B, failing to provide safe social care. That's been reviewed, and that will be presented to the QSE committee on the 25th of March, and then that will form part of the board assurance framework for the next board in public.
Comments from any of the execs responsibilities?
Just very quickly, Chair, just to support the process that's in place to simplify the process, but also magnify those areas that I will reflect or we're doing better on them
Yeah.
than we were expecting. So, yeah, fully support.
Thank you. That's very helpful. Thank you, Elaine. My report as chair. So this last month has been obviously inevitable focus on the development of our operating plan. I want to reiterate my thanks to the exec team, to Sean, Stacey and Pete Shanahan as our improvement directors, who've really driven this work. It's really refreshing coming from the NHS where we've got operating guidance in the middle of the year and then an operating plan might appear before the autumn. To actually have got these two aligned as we go into the next financial year, it's a massive achievement. My sense is that the authenticity and the honesty within our operating plan are really welcomed. We're very clear about the direction of travel. We're very clear about the investment and our responsibility for those public funds. And I think it's due to be laid before Tynwald at the end of this week. There are various other engagements that executives and some of us are going to, such as Tynwald briefings, COMEN briefings, all of those things. I think there's already some comms out in public from the minister and myself. There are, I think, more excitingly, rather than hearing ministers and chairs speak, communications coming from clinicians, so that there's a real sort of talking heads approach to this about what will this mean as a clinician for my patients, for the public I serve. There is always an opportunity to improve our comms, but I think as a starting point, this year's mandate and operating plan is a real opportunity for us to drive forward some of the changes that we've heard about, to really develop that collaborative conversation with stakeholders such as safeguarding chairs, but also having heard from our colleague running the dermatology and plastic surgery service that this is what underpins what we want to do. The whole point of this is step one on improving the services we offer to the public. The hard bits of it are hard, but everybody has signed up to that. So we are not in conflict over those hard bits. We all recognise them. Areas that we've flagged that need further work are inevitable at this stage in the process, and they will be reported to the board by the executive team as they get through their completion dates. So thank you to everyone involved, and please cascade that down through the organisation, particularly to those clinical care groups who have had relentless focus on how they will develop their business cases and deliver against the operating plan over this next year. I'm very pleased that I've had some feedback around clinical leadership with some of our medical colleagues. It's great that Chris has started, and I think the reception around the restructuring that's allowing us to do in terms of having visible executive leadership is played out in the operating plan as how we will have clinicians leading various sections of this. We saw quite a lot of high achievement at the Manx Care Awards, which is the last time I was on the island. And thank you to all our sponsors. it was delightful to see our charity colleagues for the first time around those tables. And I've had numerous messages from staff that were there about how they felt valued and how they felt that they've been recognised and seen, and that's a really important event. And I think in true tradition, we should admit that this is a cost neutral exercise for Manx Care because of the generosity of our sponsors. We are about to do shortlisting for our replacement non-executive colleague for Katie Kapnos, who I know is not here, but I want to minute our formal thanks to not only for her service, but her extended service as we've gone through the process in the department. Non-executive appointments to the board on Department of Health responsibilities. I'm engaged as the chair, and I think the interviews are planned for a couple of weeks' time.
Yes.
And I asked our ministers and our Timor colleagues and contacts to actually raise the profile. I'm really pleased. I think we had 10 or 12 applicants, which is significantly more than in the past. So actually getting engagement from our colleagues in leadership roles across the system has been really helpful. And I hope to be able to report back positive appointment at the next board. I'll stop there and take any questions or queries. Thank you. Over to you, Teresa, for your report on the Horizon scan, please.
Thank you, Chair. So the usual Horizon scan details the raft amount of work that is going on in the organisation in both the care groups and the corporate support areas. The bits of the report that I would particularly want to draw attention to is that we have recently been re-accredited under the Association of Perioperative Practice. We were first awarded this accreditation in September 2022, which culminated sort of a good year and a half of really hard work working towards that accreditation standard. The team were invited back in December to re-inspect, and the report is overwhelmingly positive. It describes some of our practices around safety and quality and culture as exemplary. It was actually the same review team that did the re-inspection, so we had that opportunity for that consistency check, and it's always really encouraging when you get an accreditation for the inspectors to be very positive about the continued improvement they've seen since that inspection. So to continue to improve after that initial accreditation is really positive. And I went along to the safety huddle yesterday morning to just personally thank the team for that. I wanted just to update the board. We have talked at the board previously around some of our challenges within the breast service. We have a part-time breast radiologist, but have struggled to recruit substantively to the second post that we have for around a year now. We've had a series of locums and we've sort of managed to keep the service moving forward. We haven't managed to recruit. I think we have tried to recruit on 2 occasions and not had any appropriate applicants. We have now got some appropriate applicants and we're interviewing this week for that role. So I am hoping that the next time the board meets, we've got a little bit more of a positive update on that recruitment. However, in the short term, in discussions with the clinical director for cancer services and the lead clinician, the lead surgeon for the service, we have taken the decision to temporarily move to a 2-step clinic rather than the gold standard 1-step clinic. It is a temporary measure. We will operate a one-stop wherever we can and revert back to a full one-stop service at the earliest opportunity. But the clinicians feel this is the right thing to do given the position we are in, which allows referred ladies to have their mammogram quite quickly and to get the results of that, and then to come back and see the rest of the team if that is needed. As my report says, thankfully, only 6% of ladies who are referred do have an outcome of breast cancer. So we're hoping that this temporary measure does provide some reassurance and allows leaders to be seen whilst we continue the recruitment. We've also now formally agreed the Loganair contract, the extension of that existing contract, which comes into force from the 1st of April. We have highlighted some financial challenges with that, but I think we have mitigated some of those for the best part of the year, but we are working with the strategic air group to deal with this. This is part of a wider set of priorities for the island around that strategic air delivery. And I know Tim will welcome this news. We have, with the support of funding from one of our charities, being able to progress a new changing places facility for Nobles Hospital. Again, it has been subject to MHK questions, but that is now progressing. And yes, and my report also reflects on a really successful Care Awards made possible by our very generous sponsors, so at no cost to Manx Care. And I would just echo the chair's comments about just how warmly received and what a positive evening that was to really celebrate the very many successes and the great achievements of our staff in Manx Care. Thank you. Have to take questions on the report.
Any questions for Teresa? Tim?
Teresa's absolutely right. Welcome the new changing places facility. Really great that people who have greater needs have someone on the hospital site. I think there are some changing places across the island, so really great that we're not behind on that, and we're offering that to people who are coming into the hospital. Unconnected, but also of interest is that there has been a campaign for waste bins in men's toilets. The whole area of men's incontinence being something which has been promoted up agenda, particularly around people with prostate cancer. And there have been a number of campaigns within England to ensure that there are waste bins in men's toilets as well, so that men who do have incontinence can dispose of items. I think that is something that we've discussed in the past, and would just like to hang it here again. And then the other thing is on the horizon scan, just the estates and infrastructure element there. Really good to hear that following the retirement of one of the Christian ministers, a new Christian minister is being appointed. I just wondered whether there were any other faith leaders as part of the chaplaincy service during this month of Ramadan. I just wonder what there is in place for people who are from other faith groups and what we provide. Don't need to answer that now, but it would just be something I'd be interested in hearing about. Obviously, we just started Lent as well, and quite interesting this year how Lent, Passover, and Ramadan are all coming together as holy months for 3 major Christian groups. Thank you.
Okay, I'll provide an update on that outside the meeting if that's okay.
Thank you.
Any other comments? No, thank you. So over to an update on the operating plan and mandate, which will be a standing agenda item at the very least quarterly, and possibly more often as we get an understanding of delivery. So you're leading the secretary.
Yes, and obviously you've covered quite a lot of this in your update, Chair. But it is just to say that, yes, it is very welcome news, the approach that we have taken to the generation of the operating plan, fully aligned to the mandate and indeed the budget this year. So we have for the first time been able to lay the mandate and the operating plan simultaneously, both to our boards and to Tynwald. And I think it is important to reflect that is a different process to what had been followed previously. And I think it is indeed the first time that the mandate has been laid in Tynwald with a very objective assessment about the finances attached to the mandate. We have never been in this position before. It has been always much more subjective about whether the financial envelope awarded to Manx Care does indeed allow for all of the mandate objectives to be delivered. There's a lot of work which obviously sits behind the mandate. There is indeed a need to change and modernise how we deliver health and care services, whilst holding very firmly to the 5 sort of key principles that Manx Care have always had and have been reflected in our mandate in previous years. So it's not a shift in direction, but it is holding firm to those commitments around early help and intervention, and a commitment to deliver care locally in our communities wherever possible, home first, and also to really sort of shift, if possible, some of our resourcing from the hospital and acute-based services to the community. It's also really important that we have real close scrutiny on the care pathways and the costs of those people who need care off the island. So it is all about the appropriateness of that care, and looking at opportunities to repatriate services wherever possible. We've heard today that, over the time that the skin service has been up in Ramsey, it has managed to repatriate significant amounts of work that would have ordinarily gone off island, and provide a very high quality service here for island residents. Over the last week, the executive have been leading confirm and challenge sessions to really get underneath all of the details of the operating plan, and to be assured that the delivery of those changes is locked in, and there are delivery plans from the 1st of April, and the savings that need to be generated are also locked in. And this will require the governance of the organisation to change, both recognising that Manx Care has made a commitment that it will not progress new services that are not funded. So there's a governance requirement there for that to be communicated effectively internally, but also our governance processes to make sure that we can make those business cases and access that funding where we need to, how we access the transformation funding, how we access the contingency funding, which is held by Treasury. So, I think I'm content that we are where we need to be. I think we will be able to bring a huge amount more detail back to the board in April, some assurance on the delivery plans, on the financial plans, and what's most important in all of this, and as I say, we start this week, is that very clear communication plan aligned with the department. So we are all speaking the same language. We are all communicating consistently with the public about what these changes really do mean, and what is the impact. So our clinicians, our teams, our operational teams understand that, but so does the public. As we go through what will be a year of change, but a year of being able to demonstrate, more so than anything, what our health services cost, that we're driving efficiency and productivity, and we are achieving the high standards of care that we aspire for the organisation and for our patients. Thank you.
Thank you. Any comments from anyone? Thank you. Sorry, should we, okay, Chair. Perfect. That's good. Okay, so moving on to the exceptional reports from our committee chairs. Kirsty, can you feel on February 25th?
Thank you, Chair. Just to say, the report stands, happy to take any questions, but also to note that the integrated performance report wasn't available at that meeting, so it wasn't scrutinised. These papers do say that the integrated performance report is part of the board pack. I'm not sure if they actually were in the end or not.
It was circulated for information, Tim, so it
is, thank you. But just to say, we'll look at that one at the March meeting because it wasn't available for a February meeting. Other than that, nothing else.
Nigel?
Yeah, thanks, Wendy. We did spend quite a lot of time on the integrated performance report of PNC by way of comfort, which may give you some comfort, I think, and some assurance on that. Also, FPNC, as ever, most of the things we discussed about community have been escalated to the main board and are being discussed today. But we spent a lot of time talking about the need to change the way in which we do things and the need to communicate that upstream and downstream, and to have buy-in, hearts and minds from all our stakeholders. And we've talked a little bit about that today, so we focused on that.
Any comments, questions for anyone? No, thank you. Our standing item, people culture and engagement update, the staff survey and action plan. Helen. It's your item?
It is, yeah. Thank you very much indeed. So, I just want to start by framing staff survey as part of our listening and communications activities with our workforce as a whole. I think there is sometimes a risk that because staff survey is a large scale set piece activity, it deserves a different kind of importance than any other kind of activity. So sometimes it seems like a staff survey is given more credence than a staff group or a P&DR process or regular activities like job planning. It's my contention that that is not the case, that staff survey needs to form part of a holistic approach to conversation and communication with our workforce, and that we need to ensure that our activity to listen to the experiences and reflections of our colleagues takes place all the time and is not just boxed off as a staff survey activity. So for me, in terms of this survey, this is a point in time that needs to form part of a much more holistic approach to how we listen to colleagues' experiences as employees of the organisation. One of the ways that you can see that, I think, is in the participation rate. So 23% of colleagues who were eligible to participate did so. That is a data point in and of its own right. The choice to participate or not tells us something about how people feel about the organisation. And I think we need to take that into consideration when we look at some of the findings that come out of the report on the whole. And it's not true to say that staff who didn't choose to participate in the survey are, for example, unwilling to engage or disenfranchised or not interested in their organisation. I don't think that that's the case at all. And certainly anecdotally, in the short time that I've been here, I've found quite the contrary, actually, and that staff prefer to use a range of different mechanisms to make their voices heard, which might or might not be staff survey. In terms of what this survey is telling us, I think it triangulates very well with most of the other mechanisms of communication that we have, certainly coming through the nascent staff groups, coming through our conversations with staff side and trade union representation, that the themes and trends are very similar. So, for example, there is a focus on reassurance around staffing levels. And that's not to say that staff are concerned particularly about current staffing levels, but I think they are genuinely very interested to hear what is coming out of the operating plans and what the future of our workforce is going to be in terms of how we deliver care. I think they are very interested in workforce planning and how we create a future model for workforce, including things like career progression, things like training and development, things like multidisciplinary working. Those are all elements where staff are very interested to hear the views of the organisation and are very keen to contribute to those conversations. And so I think if we think about our action plans and activities, those are the things that need to come at the very top of our list. I think that another key thing that I just want to touch upon is the level of trust that colleagues have with each other. There is a clear sense that colleagues work well with each other, that they enjoy the relationships that they have, that there is high trust between colleagues who are working in areas of the organisation, and they would like to see that all the way through top to bottom. And so there are opportunities for us to build those connections and networks so that there is a level of transparency and openness where people feel like they are well informed and engaged in the work of the organisation, which I think is very pleasing and useful for us. So in terms of the draft action plan, there are a number of activities in here. Some of them I would suggest are a little bit aspirational. So I think, for example, the idea of creating a holistic skills audit within the life of this survey is perhaps a little bit overambitious. And I think we have to look at it in terms of actually what do our delivery plans need us to do from a workforce point of view, rather than looking at everything that we might do or could do. So I think in terms of greatest impact, best alignment with the outcomes of the survey, and best alignment with what is coming out of the operating plans from the care groups, we need to focus on building our internal comms and relationships. So how do we create channels and pathways where we can talk to each other frankly about the work that we do in the organisation? I think there is a significant impetus for us to develop workforce plans that support the operating plans. I think there is a need for us to look at how we support the development of leadership. I think we had such a fantastic case study right at the beginning of this session about what exceptional leadership looks like. That needs to be our blueprint going forward. How do we support that? And also, how do we make our organisational values a reality for people who work in the organisation? So what do those values mean in practice in terms of the delivery of our activities in our relationships with each other and also with our relationships with our patients? So I think those are the key things that I'd like to bring to your attention.
Really helpful. Can you have some questions for Helen? I'll kick off. Thank you. I think it's really important that we focus our resources this year. So I think a smaller number of achievable outcomes will encourage more staff to actually do the survey next year because they'll see some tangible benefits. I am quite interested in long-term sick leave percentages and how much you're doing because it's slowly creeping up in other places that I go to. So I'd be quite interested, I think, just to make sure that we're not missing an opportunity to support that particular group.
Yeah.
I think your comments about career progression are really important on the island. One of my many visits, I think in Ramsey again. She'd spent 25 years in Liverpool because she couldn't progress her career beyond a certain level. So I think there's something around how we can build in that flow back and forth in order to keep people here. And I think, again, that should be perhaps something we signal as part of our workforce development plans. And I absolutely take on board the need for significant leadership training, particularly for our clinicians. Many of them are doing some random things. I hear people doing MBAs and stuff. I rarely meet anyone in MBA that's got great clinical leadership skills. However, that's my prejudice. But we need to have a suite that we can offer people and support them and look at the outcomes so that we're benefiting from it, I think. And there's lots out there, but I think we need a really sort of rigorous process to say, what are we offering and how can you get it? Or we end up with people staying in those silos. So those are areas that I'd really promote. I look forward to hearing more about this in due course. Charlie.
Yes, thank you, Helen. It would be really good to get a clear picture, if we can, of why people do and don't complete the survey. And I know the people that don't engage and don't respond, you're potentially asking you to embark on a mission to engage with non-responders to ask them why they don't respond. It's a bit of a conundrum, really, isn't it? But I think it's really important to try and dig into the weeds of that and get some real clarity. What is it that drives people to complete the survey? What drives them away from the survey, and how can we use the ones that do to create kind of change agents within the workforce to encourage the ones who don't? But initially, do you have a feel or an indication as to any themes as to why people don't? Culture, apathy, lack of trust, suspicion? Yeah, any indicator of this?
So on the whole, the literature around staff survey suggests that people who are fine don't tend to fill in the survey. So if you think about a curve of normal distribution, the people in the middle who are generally everything's fine, they're not the people. It's the people who are at the end of the bell curve. They're either violently disengaged or violently engaged for whatever reason. They tend to be the people who fill in staff survey, which is one of the reasons why I kind of just play a little health warning card with regards to staff survey, if it's our only mechanism for listening to what staff say. For me, the bigger piece of work is around maturing our network groups and engaging people where they are. Because staff survey is a very formal set piece, and it comes with it a lot of those risk factors around managerialism and an organisational approach, when in fact what we want to do is listen to people's real experiences. And as soon as you create a questionnaire, it constrains that discussion. And that in itself is quite putting to some people, because they don't feel that the questions represent their lived experience. So I think there's something about using those staff groups and networks and working with our staff side colleagues to have a much more conversational approach to how people are experiencing life at work.
Okay, thank you, that's helpful. Tim?
Yes, really welcome that approach to have an ongoing conversation and dialogue with people, rather than just having an individual survey once a year and everything then falls from that. And that does then afford the opportunity to try and hear from groups or from individuals who are sometimes referred to as the hard to hear voices or the seldom represented voices. So really important that we do that, and that's, as I know it will be, as inclusive as possible. And also really welcome that a 39/40 recommendation action plan is gripped and subsumed into actions which are manageable and doable. The negative side of that, of course, is that, again, it's potentially one of those times where we say we're going to do something and we don't deliver on it. So the communication has to be really good throughout that. The one recommendation I would particularly refer to is 19, which is about the equality and diversity inclusion strategy. That's a pullover from last year's as well. So that's, I think, for whole groups of people, that is, it's not the be all and end all. It's just an outward and visible sign of where the organisation is culturally and whether the organisation thinks that that's important or not. And having not done it 1 year, and then if it were dropped again this year, again, I think just gives a really strong message. So really welcome the streamlining and having that ongoing conversation. Thank you.
Thank you. Nigel?
Thanks, Audrey. Helen, I really welcome what I perceive to be a back to basics approach here, and getting into the communication of it, because we talked about it earlier. What is imperative to our delivery this year is going to be the management of elegant change. And that will rely on the right kind of communication at the right time. And, you know, if you work in any organization, one of the observations that you often hear is that they don't tell us anything. They don't know where we're going, or we don't know what we're doing, or we don't know where we're going. So if you can promote that group culture where there is an outlet for what people are really feeling and believing in, and, you know, will give willingly, they'll tell you what's wrong with the organization if you provide the opportunity to them to talk or to communicate, rather than swamping people with emails. You know, even us, I suspect, as non-executive directors, log into Manx Care and 50 emails are downloaded. You lose the will to live. If you've done a 12-hour shift, you know, and you've been working very, very hard in the thick of it, and all you want is a glass of wine and a box of chocolates, and you open your laptop and see 50 emails, it's pretty daunting. So I really like this idea of yours to get back to basics and hear what people are thinking and allow that to permeate up and down. Thank you.
So thank you. I think what we've heard is that there's a real appetite for focused engagement and what we learn from it. I suspect it might be quite nice for us to have some sort of contour map of where do we engage and what do we learn, because there's the Robert Care survey with a 98% response rate or whatever it was, and various. So I think there are a number of things that we can learn from that we may not be doing, but they're about us. So I think at some stage it'd be really helpful to see, because I think your view and the exactness of the weighting of those is going to be really important as we make sure our engagement staff is at the correct level. So thank you very much. Right, we will move on. So we've got finance report on January management accounts. Jackie.
Thanks, Chair. So you'll see the management accounts are in the pack, but I just thought I'd draw out a couple of key points for the attention of the board. So you'll note that the forecast year-end position has moved. The deficit is now 15.8 million. That's a movement of just over $1 million a month. It's the primary driver of that move has been the recent decision by DHSE, Treasury and Government to reverse the decision that the Manx board made as part of the savings plan around on Ireland elective activity. So before that point, we were aiming at our 15 million control total, which had been agreed by government. So the additional 0.8 million is directly as a result of that government decision to reinstate that initiative. We've also had some small movements in the month around the necessity to strengthen staffing in our medicine care group around some specialty doctors. And we've realigned, we've made some small amendments to our CIP forecast to the end of the year to reflect a level of risk in there. In terms of the position from month one, that forecast position represents an overall improvement in our forecast of 1.8 million since where we said we were going to land at the beginning of the year. That's a relatively modest movement in the context of the size of our budget, but it belies a number of rather large movements underneath. So since month one, our CIP performance has improved by 7.5 million. So we recognised at the beginning of the year there was a lot of risk in our plan CIP. We worked really, really hard to drive that to its absolute maximum in this year. So we've delivered an extra 7.5 million of savings in this year compared to what we anticipated at the beginning of the year. On the opposite side, a number of the risks that we highlighted at the beginning of the year have materialised. Many of these risks are largely demand-led, so things like our tertiary activity, expensive packages of care, and subsequent contract costs. Another big mover in there was the recent pay award, which again is largely determined outside of government rather than a decision that was taken by the Manx Care Board around that award. And that's been partially mitigated by the use of the DHSE reserve in this year. So that award has been funded in this year through the DHSE's own reserve, and additional funding has been provided into next year to make sure that that's supported on a recovered basis, which is very, very welcome, very important. And then year to date, again, one of the main drivers of our CIP is our focus on bank and agency spend. So this year to date, we've spent 4.2 million less than we spent to this time last year. That's a massive reduction. A lot of that is driven by our continued focus on agency spend, and that's supported by a lot of the recruitment activity that's happened. And it's borne the fruit of activity that's been happening over 12, 18 months and longer. So that's welcome. In this year, we've shifted our focus to provide a little bit more focus on our bank. And again, some enhanced controls around that area have seen that number now start to drop below prior levels. We are now operating in these two areas at spend levels lower than when Manx Care came into being. So that's a massive achievement since we began. And that will continue. We're forecasting that to continue even further into next year as part of our continuing CIP. And so far this year, our CIP has delivered 9.3 million of cash out spend reduction savings. And we anticipate that it should deliver close to 12.4 million by the end of the year. So happy to take any questions on that.
So thank you. So our board agreed forecast deficit 50 million, and it still is the 800,000 paid by our minister. So that's acceptable. Thank you. And do you just want to talk about the supplementary vote, just so that we've got public record of our position and why it's going to be different at the vote?
Yeah. So the department is due to table a supplementary vote to Tynwald to cover the forecast deficit position to the end of the year. We communicated to the DHSC that our anticipated forecast deficit is the 15.8 million we described, understanding where the 0.8 million has come from. And the DHSC will be tabling a supplementary vote for more than that amount of money. And that's a prudent approach to take at this point in the year. And what that's reflecting is what we're telling them about our expected year-end position, but then accommodating a level of risk and contingency that allows for any flexibility. We don't anticipate that happening, but it's entirely sensible for the department to adopt that approach and going to Treasury to seek that funding. It's also important to note that the terms of any supplementary vote funding is that money doesn't flow into the DHSC or into Manx Care. That's an amount of money that's set aside on a contingency basis to cover the need. So whatever it is that we spend is what will be drawn down on a one-off, non-recurrent basis. So it's not like 20 million will now, if it's approved, will be given to Manx Care. Simply the shortfall that occurs at the end of the year is what would be covered by it.
Very helpful. So I think just going back to the point you made, Teresa, that last year or this year, right? Next year, we're starting the year in a very different position because we're not retrospectively trying to fit our budget mandate and operating plan together. We are in a position of having agreed that. So we will not be in month one forecasting a deficit. We can't do that. We have agreed the operating plan where we are. So it's a completely different approach that is built on all years of experience that we've had. So I look forward to closing down this year relatively soon now. Where are we? 11th of March, not long to go. Just thank you to you and Pete Shannon for all the work around this, because what we see at the board is not the detailed discussions around individual pots of money and budgets, but also Sean, to you and colleagues around the work that's been done with clinical care groups. And thank you to the finance team, because I know that their work is not yet over. Year end is always a busy time for everyone. So if you could convey our thanks to your team, that would be really great. Any other comments from anyone?
Yes, I think just a general comment, really. I think that understandably and quite rightly, because of the way we budget and the way we finance matters, we look at rolling years. So we look at closing a financial year and opening a financial year. I would encourage us to look a bit further than that. And I'd encourage our stakeholders to look further than that, in that we are in the last 2 months of the next 15. We're in the next 12 months of the next 60. So we're actually on a 10-year journey here. And change doesn't happen overnight because you rebrand something. You have to change cultures to make things happen. And that's going to take time, both in our organisation and outside our organisation. So I would encourage us to look at the next 12 months as the first 12 months of the next 16. Thank you.
Trying to do the maths, but I think you're right. That's the next.
You worried if I wasn't.
So yes, but I think it's a point well made. I mean, we are subject to the usual accountancy rules of year end, etc. But I think the operating plan does signal the future pathway. And I hope that in the same way, the sort of co-production and the check and challenge we've had around producing that we'll start the next year's mandate discussions much earlier, and we'll have much more collaborative and realistic approach to the ambition in the next mandate and the one after that. So I think you're right, Nigel, to flag that this isn't just a sort of breathe a sigh of relief, move on to the next year. We can't, as people responsible for health and social care, think in 12 months how they function. Okay, any other comments for Nigel? Sorry, Jack.
If I just now that
Glasses being waved.
Nigel raises an excellent point, and it's important to note that just from a timetable point of view, yes, we have year end, we finish one and start another, but immediately, and we've already started the work, we start preparing what our financial plan for 26-27 is, because that needs to be finalised and submitted by July, which is not that far away. I think it's really important that we don't lose the momentum, the very excellent momentum that's been had in terms of getting to this position with our mandate and operating plan and budget being aligned, and making sure that the next round of funding cycle has those three things aligned at that point, rather than doing it after the effect. And I think, if we, that to me is the nirvana, is that the financial ask that goes to Treasury middle of the year is supported and aligned to a mandate and an operating plan. And they all sit together then, rather than we've had to do it after the fact this year. So that would be my plea for this coming years. We definitely need to be thinking 2-3 years ahead at least. And we need to continue those discussions with some of our government stakeholders around a much firmer view of what a 3 to 5 year funding settlement might look like. We have indicative figures in the Pink Book, but we all know from experience that every year there is a negotiation about what that number looks like. So from a financial planning point of view, it's not secure in the way that we would do if we said this is what your funding is going to be each year. So I think we need to continue those discussions for our longer term stability. John?
Thanks, Chair. Yeah, I fully support that proposal by Jackie to think about it. But can I just encourage that the board encourages the organisation going forward not to just focus on the money. So this is a service that's here to care for people. And one of the things that it's finding it difficult to understand is the activity it needs to do to care for people. And that is in itself driving the challenge around its money. It's also driving the challenge around the way government plan the budget for Manx care. So it's really important that planning is undertaken and started early. And Manx care obviously needs to support the DHSC in understanding, alongside public health, the activity that is needed and what that activity looks like in terms of its delivery, whether it's an individual requiring care in a nursing home, whether it's care supported at home, whether it's a GP's appointment, a dentist's appointment, or whether it's an operation. And I would encourage that the organisation begins that process early, works collaboratively with the DHSC, and not only focuses on the money, but actually focuses on the activity that the island needs to deliver year on year to sustain its services. And it works closely with Treasury to ensure that it gets a good cut year on year in terms of delivering the care that the island's people need.
I absolutely support that. I think that's partly why we've been successful at this stage with the operating plan. We've talked about what you'll get for it, what does care look like. And I think, so our traditions, there's obviously indulged to set the money before you set the clinical outcomes. So we now have an opportunity to change that. So the first quarter will be really important in terms of delivery. The second quarter will be really important in terms of aligning the following year's budget with the activity, with the outcomes and clinical progress, etc. So we're now in a much more positive vortex of change. But it is really hard work as well for everyone. Jackie, final comment.
Thank you, Chair. Just building on what Sean has said. Absolutely, from a financial planning and a financial control point of view, having absolute clarity on what it is that we are going to do and what we're going to deliver and how much of it we're going to do and in what configuration, all of that is what spits out the number, the money at the other end. So a big part of what we do here in finance is reporting on what's happened. So if we've got a much clearer picture of what that's going to be, it's much easier to exercise planning, control, governance, and all of the things that we want to do. Because money is simply the end result of the activity that we do. So if we control and manage and monitor activity appropriately, as Dawn said, theoretically, the money should sit properly if that has been done properly in that planning piece. We've got a way to go in terms of aligning those. We're still developing that, but I think it's really important we keep that at the front of our minds.
Sure, I'm Pete. Sorry.
Just change your name.
He is my favourite British actor after all, I mean, you know. Sorry.
The other thing we've started to do is actually get them to think about needs assessment. Because as you know, in the UK, we always have like a JSNA, which is done regularly. I think last one here was done in 2017.
Okay.
So there's no like engagement around like what's the population need and what the priority is. And you know, really, although it might make things difficult in some ways, it's actually better if someone else makes that decision. So they can advise the politicians.
And I think we have an opportunity with changes within the department to actually have that positive, what's your role, what's our role conversation, which we've sort of started over the last 6 months to have. And I think it comes back to me. I think the very first thing I said a year ago was that understanding the governance of how decisions are made, how we deliver health and social care, is crucial if we're to actually improve things. And that extends to others, our stakeholders and our colleagues in the department as well. So I think it's a point well made. And I think it's, my sense is that these watershed moments of publishing a mandate, publishing an operating plan, they're also an opportunity to say, and then, and I think that's one of the areas that we want to think about to say, on the long list of things we've thought about. I do think we need to have a sort of, so what would the future horizon planning look like? And where do we have to be ready? And where do we turn to our colleagues to say, well, actually, this is your business? And that, I think we're a confidence in our own abilities and the abilities to actually have that now. So thank you. Tim.
I don't want to prolong that, but just starting the whole issue of population health and health needs, and planning that 5, 10, 15, 20 years in advance is really important, and completely agree with the point made about the JSNA and about the island plan needing to be integral as an island plan, but also to part of that to be an island health plan and a health and social care plan, so that plan looks at both the infrastructure of the island, but connects things like housing in as well. We all know about Maslow's hierarchy of need, how important that runs through. So I think, and then if we have a plan and we have an assessment of needs, so that we know in general terms, in 5 years' time, we're going to be doing this amount of X and this amount of Y, that makes all our lives so much easier and better outcomes for the population as well.
Okay, no, thank you. So I've not been notified of any other business. We have some questions from the public. So I've got early submitted ones from Mr. Tim Cully. So thank you very much. They're around the Manx Care Record project. The answers to the questions are that the DH is currently targeting the development of the business plan. Sign off is likely to take a few months. The plan is due in, I think, Q3 of this coming year, so October, December time. The complexity, as I understand, it's due to the total value and the nature of governance approvals that will go through DH Treasury, Code and Tibble, as well as us. So DH are the leaders on this. A question about will there be market engagement? And if so, when is this planned? Our understanding is that yes, the department is intending on having a pre-market engagement in Q2, so completed by September of 25. Date to issue invitations to tender. DH anticipate issuing the invitation to tender in 2026, and the estimated date of the contract award. DH estimate awarding a contract, handing over the delivery of that contract for Manx Care Record to Manx Care in 2026. These are big questions with short answers. And I just want to assure Mr. Cullen that this is a project that's very close to our heart. We will be keeping a very close eye on it. We are very pleased that we have the initial support from the department. But this is a massive opportunity for us to really make a stepwise change in health and social care. So we will be watching that carefully. And Mr. Mann, thank you for your questions. They're quite clinical and complex, so we've agreed that Sheila will coordinate a written response to you as soon as possible. I think we answered the ones earlier. So thank you very much. So on that note, just say thank you to everyone for walking. We have finished early, which is extraordinary. So we've actually hit some oxygen because I feel this room is about to explode. But thank you very much, and we'll see you all next month.